this is just the country overview. I think it's clear that there's 11 countries in the One World No Hunger program for food and nutrition security. The nutrition baseline surveys were done on 10, and this shows you how they fall within Africa. And the two countries in Asia are India and Cambodia. In general, economic growth has been quite high. It was a large undertaking, and so I can't say enough that this is some preliminary results. But we do know the hypothesis that we want to test, and maybe you'll come up with more at the end of the seminar for us to test. But the first is that women's dietary diversity, it could be measured by the average or by the threshold of minimum dietary diversity for women, will be higher for households that have more diverse agriculture production pattern and better knowledge of adequate nutrition. And then basically the same thing for the children. That minimum acceptable diet will be higher in those households that have more diversified agricultural production and higher level of nutrition. So when we look at the dietary diversity for women, we in fact were happy to see that in 9 out of the 10 countries, there is at least 1 and a maximum of 3 agriculture variables that were significant. Agriculture factors weren't as predictive, so in only 5 out of 10 countries was there 1 and a max 2 of these agriculture factors that were significant. And really important is that the infant's age, so again, if we're looking at what's predicting minimum acceptable diet, the age of the child is quite important. So there are very general conclusions, but I think it's quite clear in my interpretation of the indicators and having worked with these indicators a lot, that the areas that were chosen by the program really are very vulnerable. I mean, they're areas with either both high food insecurity and low dietary diversity of women and children, or some of those outliers in Ethiopia, India, where they reported less experience of food insecurity, but yet their dietary diversity is really not good. So focusing on dietary diversity of the women and minimum acceptable diet of the children seems very appropriate. And it also seems like the program interventions that I read about, which mainly are on agriculture, ag inputs, diversification, we might need to tweak a little bit, really focus on diversification of the production system, support to ag extension, support to health extension, behavior change communication with the mothers through cooking groups, women's groups. There's many different strategies. So they differ on the country, but that in general, this philosophy, and then the last one, super important, is the multisectoral support. So support to scaling up nutrition bodies, support to multisectoral committees at district level, I think also very important. So a good match. And then when we think about impact pathways, I do find that they'll be quite plausible with the package of interventions to meet the objectives of the program. All right, so some general recommendations just to think about. That not only do we need to have these baselines and inlines, what happened at time A, we did some interventions and now we're in time B. What happens in between is super important. So what they found in that impact evaluation was that the number of times that the woman goes or the family goes, the number of messages they receive, the frequency and intensity of the interventions is really important. But there was a divergence between households who claimed to have access to fruits and vegetables through wild collection of fruits or having fruits at homestead and having a home garden where they grew vegetables and their actual intakes. In terms of care pillar, country-specific qualitative data is needed. We've gone through that a lot, I mean, particularly in Ethiopia and Kenya. What's going on? They had the knowledge, but they couldn't meet the practice. So what's happening with that? And, you know, lastly, in terms of health and WASH, there were lots and lots of household data on hygiene and diarrhea prevalence and how the woman takes care of child with diarrhea. But what struck me from when I really looked at the data was this very low access to safe sanitation. So in some ways, of course, household sanitation can improve. But if basically the population doesn't have access to toilets and they're using, you know, the bush, it's going to be very hard to really pull up, I think, your health conditions in general. Okay, and with that, thank you very much for your attention on a Friday afternoon.